So far, we've only been talking about color Doppler and spectral Doppler of flow. Now we'll move to another modality, to tissue Doppler. We can measure the tissue Doppler velocity both at the medial and at the lateral annulus of the mitral valve. You will get a slightly different spectrum. You will get a higher E' wave if you look at the lateral versus the medial signal. But in both signals, you will have a wave which kind of mirrors the mitral inflow with an E wave and an A wave, only that is called E' and A'. Again, E' and A'. You will need this measurement if you want to assess diastolic dysfunction. But let me show you on a demo how to actually obtain such a signal and what considerations you should make.
In principle, you have two possibilities to assess the velocity of the mitral annular plane, either at the medial vicinity or at the lateral vicinity. So I'll first show you how to do it at the medial portion of the mitral valve ring. The first thing is you try to get the spectrum as small as possible to enhance or increase your frame rate. Then you put the color Doppler, the tissue Doppler spectrum over the medial annulus, and then you put the pulsed wave Doppler signal right at the area where the ring is, and you will receive a spectrum which looks like this. What can you see? First of all, you see systole here, and you see diastole here. This is the E wave, and this is the A wave. What you would need for the E to E' ratio is this velocity. In this case, it would be 0.12. So he had normal E velocity of something in the range of 6 or 7, so the ratio would be somewhere in the range of 5 to 7 would be his normal E to E ratio. You can also perform the measurement at the lateral ring. All you have to do is switch the region of interest to the lateral ring, then put the pulsed wave Doppler signal there. And again, we get an E wave or E' wave and an A' wave. Here the maximum velocity is 0.18, so you will usually see a much higher velocity of the tissue Doppler E' wave with the lateral ring opposed to the medial ring.
The normal values for the tissue Doppler signal of the E' wave is 10 centimeters for the lateral and 7 centimeters for the medial annulus. Where do we use pulsed wave and tissue Doppler of the mitral valve? First of all, to look at mitral stenosis, to assess diastolic dysfunction. For timing, it's ideal to really determine, for example, the isovelocic relaxation time, to look at whether or not a patient has sinus rhythm or not, and also to determine if a patient has pericardial constriction. Of course, we'll also use color Doppler in a 5-chamber view. My recommendation: place the transducer very lateral so that you get a very parallel orientation to the blood flow. You see the septum is slanted. That's what you're trying to achieve. What can you see in this view? Aortic regurgitation. A beautiful example of a very small jet. You can see that it originates here from the center of the aortic valve. But that's not all. It's possible to detect the aortic stenosis here as well. You'll see flow acceleration at the valve, and you can also see flow acceleration in the LVOT. And it's very important to look exactly where this flow acceleration actually happens. If it happens at the valve, it's obviously a valvular problem. If it happens below, it's a subvalvular problem, or it could also be a subaortic membrane. Next on our list is pulsed wave Doppler of the LVOT. Here's a demo.
For the pulsed wave Doppler signal across the LVOT, it is important to first acquire a 5-chamber view. So we'll start with the 4-chamber view. This is the 5-chamber view. To optimize the 5-chamber view for the LVOT measurements, I would recommend that you move the transducer a bit more lateral. And if you do so, what happens is that you are oriented much better with respect to parallel alignment of the ultrasound beam than the classical 5-chamber view. And so in this view, I would then place the pulsed wave Doppler signal in the aortic valve, then optimize the baseline and, of course, the speed with which you were recording. What you have here is now you have very sharp echoes. This means you're right in the valve. And so from this position, I would go back a bit until you're safely in the LVOT. This is usually when those sharp echoes are gone. Okay? You usually see that the velocity is a bit lower here as well. Okay? So this would be a very nice signal, and here you could actually perform all the measurements you would want to do.
The maximum velocity across the LVOT depends on the size of the LVOT and also on the stroke volume. But usually it's in the range of maybe 1 to 1.3 meters per second. What can you detect with the help of the signal? Where do you use it? You're going to use it for calculating the aortic valve area with a continuity equation, for calculating stroke volume and cardiac output, for shunt calculations, and if you want to look at LVOT obstruction, because there you can scan the entire LVOT and look at the spot where flow acceleration actually occurs. It's important to use not only pulse wave Doppler, but also continuous wave Doppler in all of your patients. In the following demonstration, I'm going to show you how this is performed and how important it is to also adjust the focus point.
The continuous wave Doppler across the aortic valve is very similar to the pulse wave Doppler. Basically, you would perform it when you're expecting higher velocities. But there's just a few points that I would like to make. First of all, we have the same transducer position as we had before, 5-chamber view, but a bit more lateral so that you have a better orientation with respect to parallel alignment with the ultrasound beam. Then you would place the continuous wave Doppler beam across the aortic valve. And the only difference you have here is you do not have a sample region of interest, but what you have is you have a focus region. And this focus is of importance because if you move this focus point, you will all of a sudden get a worse quality of the signal. I'll demonstrate this here. Right, this is the focus point exactly at the aortic valve where we're expecting the highest velocity. If I move the continuous wave Doppler focus point away, the quality of the signal will degrade. I'm going back to the aortic valve, and you see all of a sudden the quality gets much better. So the point I'm trying to make is use the focus point of the continuous wave Doppler. You will greatly improve your quality of the Doppler.
The normal velocity across the aortic valve is somewhere between 0.9 and maybe 1.7 meters per second. If you have more than 2 meters per second, we usually call it aortic stenosis. Here's an example of a patient who definitely has more than 2 meters per second. It's 6.4 meters, which is severe aortic stenosis. More on this in the chapter on aortic stenosis. But of course, you'll not only pick up aortic stenosis with continuous wave Doppler, but also LVOT obstruction, as for example in hypertrophic cardiomyopathy. So where do you use continuous wave Doppler? To quantify and detect the aortic stenosis and LVOT obstruction in hypertrophic cardiomyopathy. We've looked at the mitral valve, at the aortic valve. Next we look at the tricuspid valve. Again, in the 4-chamber view, we're going to place the color Doppler sample box right across the tricuspid valve and look for tricuspid regurgitation. This is an example of a patient who has massive tricuspid regurgitation. But we don't only look at tricuspid regurgitation, we also look for tricuspid stenosis. If you have turbulent flow, as is nicely visualized here in this image, there would be high suspicion that this is the case. Once we found a TR signal, we don't stop here because now we want to quantify the maximal velocity. We will need that to quantify systolic pulmonary artery pressure. This is the kind of signal that you want to acquire. You have a very good delineation of the curve. It's easy to measure the peak velocity. Aside from the maximum velocity of the spectrum, it's equally important to look at the shape. Here's an example of a patient who has a more triangular shape of the TR spectrum. This usually denotes that tricuspid regurgitation is very severe. What is the normal velocity of the TR jet? Well, that depends on age, because the older you get, the higher TR velocity will be. But there's a cutoff value, which is in the range of 2.8 to 2.9 meters. If you have a velocity that exceeds this, there's a high suspicion that the patient has pulmonary hypertension. In summary, where do we use the continuous wave Doppler spectrum across the tricuspid valve? mainly to look at systolic pulmonary artery pressure. Of course, we'll talk much more on this topic in the chapter on TR and pulmonary hypertension. Now let's go back to tissue Doppler and see how we can use tissue Doppler for the assessment of right ventricular function. This is how you would perform a tissue Doppler evaluation of right ventricular function. We do that from an apical position. We optimize the right ventricle. The next thing we do is we try to reduce the sector width simply because we increase the frame rate, which is important for tissue Doppler. Then we would put the color tissue Doppler display and the pulsed wave Doppler tissue display. Freeze the image, perform a calculation of the maximum velocity during systole, which is 0.12, in this case normal. This is systole, this is isovolemic contraction, and here this is obviously diastole. We're not completely done yet with the tricuspid valve. We can also use pulse wave Doppler here, even though I do not do it routinely. But I do it if I have the suspicion that a patient has tricuspid stenosis. In general, however, be aware that the velocity changes or varies strongly depending on the respiration. During inspiration, it is usually more. And finally, you can also use the pulse wave Doppler across the tricuspid valve to look at pericardial constriction. The normal velocity of tricuspid inflow is in the range of 0.3 to 0.7 meters per second, but again, be aware that it strongly depends on respiration. Now let's turn to the pulmonic veins, and let's see how we can actually record a signal there, and then let's discuss where it is useful. First of all, you need a 4-chamber view, and you have to visualize the pulmonic veins, especially the right upper pulmonic vein, which is this structure here. And then I would first place the color Doppler and just try to visualize the inflow. You can decrease the PRF, then you can see the low flow velocities of the pulmonic veins better. And then I use this as a reference to place my pulse wave Doppler sample right here at the origin of the pulmonic veins. And then you have a signal like this, where you should also bring down the filter, because if you have a high filter, you will not see anything. So bring down the filter so that you even see the low velocities. And usually the patient breathes and the signal is gone. Okay, but this would be the signal now. So what you see here now is you see the typical systolic component, the diastolic component, and the retrograde component of pulmonic venous flow. And optimally, you will get a signal which looks like this, where you have both a systolic and a diastolic component, which also has a retrograde component where flow is again pushed back into the pulmonic veins. We'll talk more about how to interpret these signals in the chapter on diastolic dysfunction. But I now want to summarize some of the things and mention general principles when you use spectral Doppler and color Doppler. First of all, always optimize your 2D image before you use any of the two, color or spectral Doppler. Look for aliasing in color Doppler and also in pulse wave Doppler, because that will show you where the velocity exceeds the limit. It will show you usually where a pathology or a jet is. Optimize the image and especially the size of the color box so that you get a very high frame rate. This is extremely important because it will make it much easier to detect a jet and to assess its severity. Use multiple views. Especially jets can be oriented in all sorts of directions. And if you move around a little bit and move towards the jet, then you will usually get a much better appreciation for the pathology. And finally, if you use continuous wave Doppler or pulse wave Doppler, always use color Doppler as a guidance. In other words, place the color Doppler box, see where the jet is, and then place the sample volume right through that jet. I guess this is it for now. But you'll be confronted with both spectral and color Doppler much more in the individual chapters. And there, I'll mention a few additional things that are important in the specific pathologies.